Hello, and thank you for joining Realities of Antibiotic Resistance and Stewardship in Small Animal Practice, featuring Dr. Jennifer Granick from the University of Minnesota Medical Center. My name is Nicole Cast, and I'm the Continuing Education Program Manager for the Minnesota Veterinary Medical Association, or the MVMA. We are pleased to be one of the hosts of the Antibiotic Stewardship in Veterinary Medicine webinar series, along with the Minnesota onehealth Antibiotic Stewardship Collaborative, working in partnership with the Minnesota Board of Animal Health, the Minnesota Department of Health, and the University of Minnesota's College of Veterinary Medicine. During today's webinar, the MVMA will provide technical assistance. If you have any questions during the session, please type them in the question and answer area. With that said, I'd like to turn over the session to our moderator, Amanda Bowden, Director of One Health Antibiotic Stewardship at the Minnesota Department of Health.
Hello, everyone. Thank you, Nicole. My name is Amanda Bedoin. I'm the Director of One Health Antibiotic Stewardship at the Minnesota Department of Health and also an Adjunct Assistant Professor in the University of Minnesota College of Veterinary Medicine. In my position, I work with professionals in human, animal, and environmental health to improve how we use antibiotics and to lessen their adverse impacts while effectively treating infections. The Minnesota One Health Antibiotic Stewardship Collaborative is made up of folks just like you, professionals interested in leading our state's multidisciplinary approach to stewardship. The collaborative has joined forces with MVMA to bring you a terrific lineup of webinars over the next 5 months. The expectation to be good stewards of antibiotics is real and present. This webinar series is intended to provide background on the problem of antibiotic resistance, the solution of stewardship, and provide actionable information for all sectors of veterinary medicine. It is my pleasure to introduce our speaker today, Dr. Jennifer Granick. Dr. Granick is the Assistant Professor in the Department of Veterinary Clinical Sciences at University of Minnesota College of Veterinary Medicine. She received her Doctor of Veterinary Medicine degree from University of Wisconsin, completed her small animal internal medicine residency at University of Minnesota, and received a PhD in comparative pathology from University of California, Davis. Dr. Granick has a clinical and research interest in infectious disease and immune response. She is also University of Minnesota Veterinary Medical Center's Antimicrobial Stewardship Lead. During 2018, she was chair of the Antibiotic Stewardship Work Group for Animal Health of the Minnesota One Health Stewardship Collaborative. She remains active in our statewide collaborative and is sought after for a national speaking on antimicrobial stewardship in small animal medicine. Thank you very much for presenting today, Dr. Granick.
Thank you, Amanda and Nicole, and everyone who's joining us today. The topic today is to discuss the realities of antibiotic resistance as well as antibiotic stewardship in small animal practice. So we'll first touch on antibiotic resistance and the scope of the problem both in human medicine and in veterinary medicine and what the companion animal veterinarian's role is. We'll talk about antimicrobial stewardship and what we can do as practitioners. We'll talk about some of the barriers that we face, and we're going to talk about some actions and tools that we can take and use. So antimicrobial resistance, or AMR, is the ability of microbes to resist the effects of drugs. And so, this is some figure from the CDC. They show us that we have some naturally resistant bugs, and when we give antibiotics to kill bacteria that we think are causing illness, what happens is that we can select for those organisms that are already antibiotic resistant. The other thing that can happen is that once we have a population of bacteria that have resistance plasmids, they can actually share those with other bacteria in the same environment. And because of that process, we can see that these bugs can rapidly outwit us as we try to develop newer antibiotics. This is a timeline that many of you might be familiar with of when antibiotics first came on the scene and when resistance was first noted. And you can see often to the right-hand side of your screen, even our newer veterinary antibiotics like cefovecin and pratofloxacin, which are later generation cephalosporins and fluoroquinolones, pretty quickly after they were released on the market, we started to see resistant organisms. So the problem of antibiotic resistance, as explained by Stuart Levy, who's an expert in the field, is that given sufficient time and use, resistance will emerge. And this resistance is incrementally progressive. Organisms that are resistant to antibiotics are likely to become resistant to more antibiotics with time. And once this resistance appears, it's likely to slowly decline if it declines at all within that population of organisms. Thus, the use of antibiotics by any one person or animal affects others because we share these organisms in our environment. So the Centers for Disease Control and Prevention, back in a few years ago, had a national summary of the data revolving around antimicrobial resistance. And what they found was that in the United States, over 2 million people suffered from antibiotic resistant illnesses. And this resulted in about 23,000 deaths. And this is a few years old yet, so it's likely that this number has increased. When we look beyond the United States and we look at the problem worldwide, 7,000 deaths occur worldwide every year from bacterial infections that we can't treat with antibiotics. And so to put this in perspective that we might be able to understand in Minnesota, this is the same number of people as if we packed 14 TCF stadiums. So it's quite alarming. In fact, there are predictions by the WHO or the World Health Organization that says that if we don't do something about this problem now, by 2050, it's likely that more people will die from untreatable microbial infections than die from cancer currently. The problem of antimicrobial resistance, though, is not limited to humans. This was a large multi-center study that I wanted to share with you that came out of Europe. And they looked at antimicrobial resistance patterns in bacteria that they isolated from companion animals with urinary tract infections. And I know that the print is probably too small, but red is bad. And green is good. And so what this is telling us is what the antimicrobial resistance patterns of these E. coli are across different countries. So, for example, in the United Kingdom, about 10 to 25% of E. coli isolates from the urine of companion animals was resistant to every single antibiotic that it was tested to. About 10 to 25% of these E. coli organisms were pan-resistant, meaning that they were resistant to more than one antibiotic, but not all of them on a panel. And only about 50 to 75% of organisms were susceptible to the full cadre of antibiotics in which we would treat E. coli with. And so this is quite alarming. They looked at other organisms as well. So, for example, staph, Pseudodermatitis had similar susceptibility patterns as the E. coli that I'm showing you here. So that's the story in the UK. What about in the United States? We don't have a lot of nationwide data, so I thought I would bring this closer to home. And so right here in the Veterinary Medical Center in our ICU, and this is now a few years old as well, 37%, so over a third of isolates, E. coli isolates from our patients in the ICU were multi-drug resistant. And only a third were sensitive to all antibiotics tested. And this is different than, the healthy animal that comes into community practice, which we have far less multi-drug resistant organisms that we see in these patients. However, let's remember that the patients in ICU once were community practice patients as well, meaning that over time, when these animals have diseases that we treat with antibiotics, they again become more and more resistant because this resistance is incrementally progressive. So this figure is from the Centers for Disease Control and Prevention, trying to explain to the public how antimicrobial resistance spreads among a community. And so you can see George up in the right-hand corner gets an infection and he's treated with antibiotics. He may go home and now have selected for bacteria in his gut microbiome that are now resistant to the antibiotics that he just received, and those organisms may spread to his family members and his coworkers. If George's illness is really severe, he might be hospitalized at a healthcare facility, and now he has the opportunity to receive and share resistant organisms with workers and other patients in that healthcare facility. Similarly, all of the members of the community may be exposed to antimicrobial resistant genes through their exposure to agriculture, both meat products as well as other agricultural commodities. What I want us to realize, though, is that George is probably like 60% of American households, and there are likely some pets in George's life. And while George can share his resistant organisms with these pets, we treat our companion animals very similarly to how human patients are treated. So if we have a pet that we see that we think needs an antibiotic and we treat a potential infection, that pet, let's name him Rufus, will be able to spread resistant organisms in the community in the same way that George can. And in addition, we also have the situation in which many of our pets are being fed raw meat diets. And so there's the risk that they get resistant pathogens directly from their food in that way. This is important, and it's important for us veterinarians to explain this to our community members, because our companion animals share our environment. We treat our pets with the same antibiotics that we use in human medicine. The same classes of antibiotics are used in both healthcare settings. And our pets, again, eat meat-based diets, so that puts them at risk, but it also puts the household members at risk as well. So there was an interesting paper in 2013 that looked at the microbiota of skin of family members living in the same household. And what they found was if there were two individual humans living in the same household, they shared a little bit of their microbiome. However, if you put a child or a dog in the household with those two people, then they shared a lot more of their microbiome. So the dog was a vector for sharing bacterial organisms. There have been increasing reports of companion animals that are colonized with multi-drug resistant bacterial organisms. And these are often harbored in the gut. Just like the skin microbiota, these organisms can be shared between pets and humans. And so there are the sporadic case reports that we hear about in which, for example, a pet shop worker is infected with a multi-drug resistant organism, and when they went back to look at those pets in the pet shop, many of them contaminated with the same organism. So a recap, antimicrobial resistance is a growing problem, and antimicrobial use in companion animals likely impacts AMR in humans, and the reverse is likely true as well. So let's take a moment and take a closer look at veterinary prescribing. Again, we don't have a lot of data, but there is some data out of the UK in which they have a large electronic medical record-based surveillance system, and so they can gather data from many, many practices across the country. And so in this particular paper that was published recently, they looked at the frequency of patients that received antibiotics for specific conditions. And so in this case, they looked at respiratory disease, gastrointestinal disease, and patients that received antibiotics post-operatively. So you can see that about half of feline patients that presented with the upper respiratory condition were treated with an antibiotic, and about 40% of canine patients. Let's just think about the human reality. About 40 to 50% of human antibiotic prescriptions are unnecessary on an outpatient basis, and many of these are prescribed for upper respiratory infections. In human health, they have gone through great efforts to try to inform patients that likely they don't need an antibiotic for the condition. And so I think that this data shows that we likely face the same problem in veterinary medicine, and this is an area that we can maybe concentrate some efforts. Gastrointestinal disease is another area where there's frequent antibiotic prescribing. So the dog that comes in with acute diarrhea, for example, 38% of these patients in this UK study were treated with an antibiotic, and 29% of feline patients. And then post-operative antibiotics were provided to both feline and canine patients about 10% of the time. And so certainly there may be situations where post-operatively a patient needs antibiotics, but if it's an elective surgery and the procedure is done sterilely, then there's pretty good evidence that antibiotics are not needed in that situation. So the World Health Organization has designated high priority, critically important antimicrobial drugs that they feel are necessary and to be reserved for humans with multi-drug resistant bacterial infections. Among those that are considered highest priority are third generation cephalosporins. This is a paper from the same group out of the UK, and they looked at patterns of antimicrobial prescription in cats and dogs. So they really were just looking at frequency of prescriptions. And in dogs, you can see that the frequency of fluoroquinolones, third generation cephalosporins, and macrolides, all considered to be critically important antimicrobials by the WHO, are pretty low in dogs. But in cats, we see this really marked increase in third generation cephalosporin prescriptions. Almost 40% of all feline patients receiving any sort of prescription received third generation cephalosporin. In another study, again by the same group, they looked specifically at cefavecin use. So cefavecin is a third generation injectable cephalosporin. And they looked at over 1,000 cats that were treated with cefavecin, and they looked at the medical records. And only in 0.5% of these cases were cultures performed. So a third generation cephalosporin, considered to be critically important by the World Health Organization, was given to feline patients without evidence of an infection or clear evidence of infection. And certainly we understand that we are often limited by the owner's pocketbook. And so we are not always able to do cultures. Depending where we practice, cultures may be really cost prohibitive. But we can offer to do cultures. And in this study of UK veterinarians in cats treated with cefavecin, culture was only offered and declined in less than 1.5% of patients. And so this is an area potentially where we as a profession can do a little better. So a study looking at companion animal practitioners and antibiotic use, including practitioner perceptions, found that most veterinarians felt that their own clinical experience was more valued than available guidelines for prescribing. About 1/3 of these veterinarians routinely cultured at the time that they were prescribing antibiotics. About 2/3 said they seldom or never performed culture. They often, of those that seldom performed culture, they said they did if initial empiric therapy did not clear the infections that they were trying to treat. Most of them felt that the cost of culture and the length of time it took to get results were a barrier for performing culture. They said if there was cheaper testing and more rapid results, then they would likely increase the amount of culture that they were doing out of their practice. So this is a figure out of the human healthcare, and it's a framework for how antibiotics are used. And so certainly physician attitude, including our clinical experiences and our training, is only one component of why or why not a particular antibiotic may be given to a patient. Certainly, there are patient attitudes and desires. So, for us, that's the human at the other end of the leash. There are also healthcare or system-wide factors, and so for us, this might be our practice protocols, our practice culture, and then there are also social interaction factors. So, are you a junior practitioner? Are you a senior practitioner? All of these things may be influencing how and why we decide to prescribe an antibiotic. So it's not just book facts. There's a lot more to it. In fact, Dr. Jody Lulich here at the University of Minnesota once said that antibiotic prescribing is often an emotional decision for veterinarians. And I think that's really wise. It's definitely true. Our jobs are very emotional. And I'll just share with you an interview from an internist that was asked about, why they make the decisions that they make. And so I'm going to quote here. In the exam room with a pet owner, we naturally focus on the trees, not the forest. I mean, if I'm speaking with a sweet elderly gentleman who's cradling his little dog in his arms, he tells me with his voice a little shaky that this dog was his wife's dog, and that she passed away 4 months ago. And this little dog is all he has left, his best friend in the world, and his only reason to get up in the morning. And he just walked into my exam room, and I just met him, and then he hands me this dog that means so much to him, and he trusts me, and he trusts that I will do everything in my power to help her feel better. He's living on Social Security. I can't run $1,000 worth of diagnostic tests, but I have to do something. That's a lot to carry. It's hard to see outside of that room, even though I know my actions have repercussions beyond this one dog, this one man, this one room. It's just hard to see all of that when I'm looking at him. And so this is a scenario that is not uncommon for us as veterinarians, and certainly something that human practitioners struggle with as well. There's this idea that if we give antibiotics just in case, then we might be doing something helpful for our patient, and we're unlikely to do harm. However, we know, at least from some human studies, that this is a misguided perception. Antibiotics are not always safe, and they may pose risk to patients as well as patients' families and communities. So we all took an oath as veterinarians to do no harm, but we need to remember that antibiotics do have the risk of toxicity and adverse reactions. We do see this commonly at the University of Minnesota. Doxycycline toxicity to the liver is something that we see not infrequently. We know that providing antibiotics to patients means that we can develop multi-drug resistance, and this is more true the more antibiotics that we provide. And the more that we learn about the microbiome, we know that providing antibiotics disrupts the microbiome, whether that's in the short term or whether those are longer term effects. We still are trying to understand how the microbiome affects our overall health, but we know that microbiome is important. So this is a study, again, out of Human Health from 2017, where they looked at consequences of unnecessary antibiotics that were given to patients in an urgent care setting. 20% of patients were given unnecessary antibiotics, and they developed an adverse drug reaction. So 1 in 5 patients provided with an antibiotic that they did not need developed an adverse drug reaction. And you can see in this chart, it describes all of the potential adverse drug reactions, including GI upset, renal toxicity, neurotoxicity, Clostridium difficile infection, which is something that we don't need to worry too much about in veterinary medicine, changes to red blood cells, cardiac abnormalities, liver toxicity, and then the development of multi-drug resistant organisms. 6% of patients that were given an unnecessary antibiotic went on to develop a multi-drug resistant infection within 90 days of that therapy. So again, we know that the microbiome is important for our health. We have, 10 to the 14 microorganisms that live in and on our bodies. And what this study in 2015 noted was that patients that were given 1 week of antibiotics ended up with altered gut microbiomes for over a year. And so the effects are more lasting than just the 2 weeks or the 10 days that we provide our prescription for. So now that we've talked about the problem of antimicrobial resistance and some of the challenges that we have in veterinary medicine regarding antibiotic prescribing, let's talk about solutions. So there are many solutions, including developing newer antibiotics, developing non-antibiotic therapy, but one that we all have power over is antimicrobial stewardship. And let's talk about what that actually means. So antimicrobial stewardship is not restricting use of all antibiotics, and certainly we don't want that to happen in veterinary medicine. But what it is a process that allows us to improve how we utilize antibiotics. It recognizes that antibiotics are important, they're a shared resource, and we need to use them to take care of our patients. So the focus is instead on optimizing use, not withholding antibiotics. So how can we optimize use? Well, there's a few different areas that we can look at. First is selection of the antibiotic. So are we choosing the right antibiotic for the infection and for the particular patient? And how can we determine what selection is appropriate? Certainly culture and sensitivity can help. Knowing a little bit about common bacteria at the site of our infections can help. Cytology and gram staining can help. So improving our selection is one thing that we can all do. Providing the right dose, so giving the right amount of antibiotic. If anyone opens up our most common veterinary formulary and looks at the doses for any particular antibiotic, we know that there's quite a large range. There's some new information about mutant prevention concentrations of some antibiotics, and most of this information is really just in vitro, and so we don't know yet how it translates to our living patients. But the thought is that if we can go higher on our antibiotic doses without causing side effects, then we're likely to avoid that mutant prevention concentration. We can get above it. Duration. So this is a big important topic in veterinary medicine right now, because we don't have a lot of good studies telling us exactly how long we need to provide a prescription for. For example, when I went to vet school, which I'd like to think is not too long ago, but now I know it is. When I was, when we talked about giving antibiotic prescriptions, it was 14 days. That was the standard. We weren't given a rhyme or reason because there really wasn't one. There was no real good justification for that, but that was the standard. And so there have been a few studies recently, at least in urinary tract infections in dogs that have simple, uncomplicated urinary tract infections, that suggest that we can decrease the duration of antibiotic prescriptions way down from 14 days to about 3 days. So there are two different studies looking at different antibiotics that showed that compared to other antibiotics given at 10 or 14 days, 3 days of antibiotics were enough to resolve the infection in these patients. And so what we need is more information about more antibiotics and more disease processes so that we can understand exactly how long we need to provide therapy for. So what's the purpose of stewardship? I liked this definition, so I want to share it with you. The primary purpose of stewardship is to optimize clinical outcomes. So I think we can all agree that that's always our goal, while minimizing unintended consequences of antimicrobial use. And that includes toxicity, selection of pathogenic organisms, and the emergence of antimicrobial resistance. So I feel like that's a goal we can all get behind. The American Veterinary Medical Association has recently provided their thoughts on the core principles of antimicrobial stewardship in veterinary medicine. So I'm just going to share these with you, but you can find them on the AVMA website. And so there's a lot of detail that the AVMA gives under each one of these, but in general, sort of the 10,000 foot view is that we all can just make a commitment to be better stewards of our antibiotic resources. We can advocate for a system of care that focuses on prevention, so we can prevent common diseases, and we have the tools for many of those. We can select and use antimicrobial drugs judiciously, and I've already touched on a few ways that we can do that. And then we can evaluate antimicrobial drug use practices. We don't really know what we're doing as a profession. There's smaller studies here and there that suggest that we are likely over-prescribing, but we don't have a global view of that, at least not in the United States. So this is something that if you have an opportunity to participate in, please do. We can also educate, and that means educating ourselves, but also educating our clients and building expertise in this area. I know that antibiotics sometimes seem scary. I felt that way when I was a veterinary student. I think that is something the veterinary students today still feel, but the more we know, the more comfortable we are and we can make better decisions. So the AVMA, before developing these core principles, actually did quite a large survey of practitioners across the country, asking about attitudes toward antimicrobial stewardship. And 77% of veterinarians surveyed indicated that they would really like to have some more guidance regarding making appropriate antimicrobial choices. So there are resources that you may or may not be aware of. I try to tell everybody I know, but copy down this website at the bottom of your screen. The International Society for Companion Animal Infectious Diseases has provided to date 3 different guidelines for specific diseases in cats and dogs. And they give us their expert opinion as well as evidence where it's available in veterinary medicine, and give us some guidance as far as what antimicrobials we should choose. The other nice thing about these guidelines is that they do provide a lot of information on diagnostics. And so that's great. These are all open access. So if you go to the ISAC website and you scroll halfway down their homepage, you'll see links to all 3 of these. And so what they have available so far are guidelines for canine and feline urinary tract infections, and they go through asymptomatic bacteria, simple urinary tract infections, and complicated urinary tract infections as well, including kidney infections. There's also a guideline for canine superficial bacterial folliculitis. And then the most recent one came out in January of 2017 for respiratory infections of dogs and cats. And this includes upper respiratory infections, lower respiratory infections. The respiratory guidelines are really, really meaty. And while they do have some tables, it's if you take a look at it, go ahead and spend the time to read through it. It's worthwhile because it talks about infectious or communicable respiratory infections as well as aspiration pneumonia. And so it's really helpful because their recommendations for each of those is a little bit different. The AVMA has also come out with some tools and information that is available through their website. They have the do's and don'ts of antimicrobial therapy, which is a few pages long, and it gives us general guidance for using antibiotics, including, first take a step back and consider whether or not there could be a non-bacterial cause for the clinical signs that we're seeing, and sort of really common sense stuff that we maybe sometimes rush through. And they also have, for both cats and dogs, and this is the example for dogs, they have a nice little figure that tells us what are the main things that we need to consider when we are considering using antimicrobials for diseases of different organ systems. They have vector-borne disease in there as well, so that's really nice. So in addition to the ISAC guidelines and the tools that the AVMA has available, there's just a few sort of broad-reaching antibiotic stewardship concepts that I wanted to touch on. First is this idea that we should be thinking about our antibiotics that are available to us in groups. So first-line antibiotics should be those that we reach for first. These should be the ones that if we're choosing to treat a patient empirically because maybe it's a first offense urinary tract infection and it you know, we pretty much know what's going on, or we are unable to do a culture because of client finances, then, or for whatever reason, we have a culture pending and we just can't wait to start therapy because we have a really sick patient or an uncomfortable patient. If we're going to empirically prescribe, the recommendation is to prescribe from this first group, this first line antibiotic group. So those include amoxicillin, trimethoprim sulfa, and first generation cephalosporins. And I just wanted to talk a little bit about each of these. I feel like most people don't even remember that amoxicillin exists, at least not in our hospital. But amoxicillin is a great drug. It's true if you look at susceptibility panels or antibiograms that, for example, we have one in our hospital that looks at the susceptibility for E. coli to a variety of different antibiotics. Amoxicillin is often not susceptible in many cases, but it depends if you're a glass half empty or half full type of person. If you have a non-life-threatening infection and you have a culture pending, then I think amoxicillin is a reasonable one to reach for. Many of us are scared to use sulfa drugs because of the side effects. And what that means is that if you look at antibiograms, actually sulfas are usually pretty good. Most organisms are susceptible to sulfas. And with the new studies out there, and I wanted to mention that the guidelines for urinary tract infections will be updated hopefully this year, will be published, and they'll provide more information about duration of antibiotic treatment. But if we can use TMS for 3 days, then we can significantly reduce the potential side effects compared to a 14-day course. And then first generation cephalosporins. And so, you know, again, cephalosporins might be something that we don't want to reach for first because owners have to give it twice a day versus later generation cephalosporins where you can give it once a day or maybe once every 2 weeks. But again, if we can shorten the duration of treatment, that makes these first line antibiotics look a lot more attractive. Second line antibiotics, which are antibiotics that I think we all use frequently, but this idea of stewardship should have us take a second look at that, include things like clavamox, third generation cephalosporins like cefavecin, and fluoroquinolones. And so the recommendation here is that if we're going to use these, they should be supported by cultures that say that the first line antibiotics are not going to work in this situation. So another aspect of antimicrobial stewardship is not just choosing the appropriate antibiotics, but also asking ourselves whether we really need to intervene with antibiotics. So watchful waiting is a concept used frequently in human healthcare and something that I don't think we often apply in veterinary settings, but we certainly could. So for example, dogs with canine infectious respiratory disease that have a non-productive cough, that are wagging their tail and eating and otherwise normal, are likely to get over their infection on their own without antibiotic intervention. Similarly, cats with upper respiratory tract infections that have had a snotty nose, for example, for less than 10 days, are still interactive with the owner, might respond to eating better if we just warm up their food and provide some supportive care. Those, again, may be patients that we don't need to prescribe to. And, you know, this is, if we think about it in the human context, you know, if we have a cold, none of us with a cold are going to go to the doctor and say, give us antibiotics. We know that this is a viral infection, and we know that if it goes on for too long, that we likely have a secondary infection, and that's the time to go in and ask for the antibiotics. And so we can apply that same concept to feline upper respiratory infections. And then lastly is acute diarrhea. And this is a real tough one, because while owners may have tolerance for all sorts of things, diarrhea is just usually not one of them. And so oftentimes, you know, for all sorts of other issues, patients come into us, you know, days into onset of signs. But with acute diarrhea, I feel like if we're open, they're here within hours. But again, acute diarrhea likely is just acute, and most patients will resolve clinical signs within 5 to 7 days if we do nothing. And again, if we provide supportive care, it's likely that they'll resolve more quickly. For example, bland diets or probiotics. Another aspect of antimicrobial stewardship is this idea of diagnostics. And so culture and susceptibility testing is great when we can do it. And we should certainly educate our clients about the importance of it, because yes, it's expensive, but if we're providing multiple antibiotic prescriptions because we're unable to get an infection under control, we might have just saved them a bunch of money if we did the culture and susceptibility from the start. Sometimes it's a hard sell. Certainly, if we have infections that are recurrent or complicated, then we definitely need to recommend culture and susceptibility. So recurrent UTIs or UTIs in which we suspect there's kidney involvement, severe pyodermas that are recurrent in respiratory disease. Cytology is something that can really help with our empiric therapy, and it also helps us interpret our culture and sensitivity interpretation. So in our hospital here, many times we get culture results back and we're not quite sure what to do with them. Maybe we grew something that we didn't expect, or we grew it in numbers that we're not sure how to interpret. But if we had cytology taken at the same time as that sample, can really help us out. We can see if there was inflammation associated with that sample. We can see if there was just one type of bacterial organism, or if it was more of a mixed infection. So cytology really saves us many times. And I always recommend that if we're going to bother to get a sample for culture, we should always do the cytology. So a few more antibiotic stewardship concepts is this idea of the antibiotic timeout. And so what this means is that we just take a moment to stop, evaluate any additional clinical or laboratory data that we might have about anywhere from 1 to 3 days after starting an antibiotic, and determining whether we need to change antibiotics. Maybe we have a culture result that came back and we realize we need to change the therapy. Maybe we started, you have a patient with pneumonia, we started with 2 antibiotics and they're doing well enough that we think we can de-escalate and go down to 1. Maybe we can go from a broad spectrum coverage and maybe we got culture results back or cytology that helps us understand that we probably can narrow our spectrum. And then another thing is duration. So again, with things like pneumonia, you know, when I went to school, we treated pneumonia for 4, 6, 8 weeks. We are realizing here anyway that likely these patients don't need to be treated for that long. And so getting patients back in to follow up earlier can allow us to decrease the amount of time that we're providing the antibiotic. So I'm just going to real quickly go through some of these main topics as far as the AVMA core principles of stewardship. So one is that they ask us to commit to stewardship, and this really needs to involve all of our practice members, from our front desk and kennel staff to our technicians and practitioners. It also asks that we identify high priority conditions. So, you know, we don't want to bite off more than we can chew, but if we take one thing at a time, we can develop maybe a program around that for our practice. Identify areas where we might be able to improve client education regarding prevention, for example. It asks us to assess the outcomes of drug therapy. So again, this idea of the antibiotic timeout. When we provide a prescription, do we know what's happening with that patient, or we assume everything got better because we didn't see them again till their next annual appointment? And then it's recommended that 1 or 2 individuals in a practice are really the ones that take the lead for stewardship in the hospital setting. So some of you may or may not know that in Minnesota, we have a onehealth antibiotic stewardship collaborative, and this involves professionals from all health systems, including human health, animal health, environmental health. We have veterinarians and pharmacists and physicians and nurses, veterinary technicians, and producer groups, all involved with trying to make a plan for the state of Minnesota to improve the way that we use antibiotics. And so if you keep checking back occasionally at this website, we are in the process of developing some tools that we can use in our practices to improve our antibiotic stewardship. What's available right now are these commitment posters that you can download for free on the website. So you can stick your photo there and say, I pledge to do my part to prevent antibiotic-resistant infections. There's some other cute ones with dogs and cats on them. They're nice to put in the lobby so folks, owners can look at them, and that might spark a conversation. We want to advocate for a system of care to prevent common diseases. And so again, do we have practices in place to talk to owners and implement programs for prevention of tick-borne diseases, for example? We can develop protocols for canine upper respiratory infection as well. With canine influenza becoming more of a problem, we can talk to owners about vaccinating for some of these non-core infections. And then again, part of prevention is infection control and biosecurity. In 2018, AHA released some guidelines all about infection control, prevention, and biosecurity in the practice setting. We can evaluate our drug use practices, and that's something that's not necessarily easy for an individual practice to do, but we wanted to let you know that we're working on that in Minnesota, both in low-tech modalities using point prevalence surveys to really get an idea of how we're using antibiotics in a clinical setting, to high-tech methods pulling data from electronic medical records. So look for that in the future, but that's something that we hope to be able to provide to Minnesota practitioners pretty soon. We want to educate and build expertise. And so again, look at the Minnesota One Health Antibiotic Stewardship Collaborative for resources that are available both for practitioner education as well as client education. Again, I believe ISAC will continue to work on clinical guidelines, and so every once in a while check back at their website and see what's available. Provide client education when you can. If you have a client coming in demanding an antibiotic, explain to them the potential risks if you think it's not indicated. And certainly if you have an opportunity to help out with any research around these areas, we really encourage you to do that, because the more we know, the better that we can improve veterinary medicine for everybody. So again, Minnesota One Health Antibiotic Stewardship Collaborative has some fact sheets that the one for companion animal veterinary practice kind of distills the available guidelines into a two-sided page. And then there's a one-page client education fact sheet. And if you wanted to download that and have it available in your lobby, you might have to do a lot less talking in the exam room. So that's what I have for you today, and I will be really happy to take any questions at this point, but I thank you all for your attention. At the top of your screen is the website address for the Minnesota One Health Antibiotic Stewardship Collaborative. I also provided my email in case you have any questions directly for me if we don't get a chance to answer those all in the next 10 minutes.
So yes, again, if you do have any questions, please type them in the Q&A area. We'll give you just a moment to do that. I know some of you don't type as fast as others. But in the meantime, I do want to thank Dr. Granick for her time in leading us in this fabulous discussion and the realities of antibiotics resistance and stewardship in small animal practice. And also to all of you who joined us online, taking time out of your busy day to learn with us. I know many of you may be asking, will I have a chance to comment with regards to this session? And yes, you will. We'll be sending out a link to an online evaluation later on this afternoon, in addition to a CE certificate for you. I have a question that came in here. What role does the pharmaceutical industry play as they develop new antibiotics and market these strongly to veterinarians?
Oh, that's a really good question. So, we need the pharmaceutical companies to develop new antibiotics because the reality is eventually the ones that we have are going to slowly be unusable. So we definitely want that. And I think that, there's this challenge that they have to provide something that they can market and make money because the R&D process is quite expensive. I think that we need to be careful, and I think it's, as the consumers of these antibiotics, we need to advocate for what we think is appropriate and not appropriate. We certainly want to have access to third generation cephalosporins and later generation fluoroquinolones because there are certainly certain circumstances where we need those. But as consumers, I think we need to give our feedback that just because an antibiotic is easy to give doesn't necessarily mean that that is the right thing to do. And I don't know. We are certainly the occasional cat that we're just all so thankful we have an injectable antibiotic to give. But most of the time, especially if we can decrease duration, the good old-fashioned antibiotics that you have to give twice a day can work. So I think that drug companies are in a sticky situation because they need to make money and profit off of the new drugs that they develop. But I think that we need to hold them to accountability, and I think that they're not going to know that if we don't give them that feedback.
Could you comment at all for those of people locally that would be attending the Great Minnesota Get Together about a booth at the State Fair?
Oh, yes, the Great Minnesota Get Together. So in the Eco Experience Building, the Minnesota One Health Antibiotic Stewardship Collaborative, for the last 2 years, and will continue to do this, has a booth where we engage the public about antibiotics. And so we've focused on disposal of antibiotics and letting people know that there are drug take-back sites and not to flush antibiotics down the toilet. We talk to them about, also any question that they have. So it's really interesting because there are a lot of misconceptions, and it's our job to sort of set them right. And so, there are plenty of people I encountered that got real aggressive about, antibiotics that we give to food animals is what's causing all the problems. But it's a good opportunity for us to give them a balanced and thoughtful response to that. Stop by, please. And also, I believe if you go on the One Health website, you can sign up to receive emails, updates, sort of top right corner, Amanda says. We are looking for more participants for our animal health group, working group. There are a lot of large animal practitioners that are involved, but so far, including myself, we only have two small animal practitioners. So we'd really love a better variety and representation. So if anyone's interested in volunteering any time towards that, it's a fun group. And so please either email me or Amanda or contact us via that website.
Another question that came in asking if the group is giving guidance to licensing boards so that they're aware of possible new guidelines that may be perceived as not meeting the standard of care based on historical use. For example, be treating for 3 days rather than the standard 14.
Oh, that's a really good question. So as far as I know, we are not providing any feedback or information to licensing boards. That's a good question. And, until we have more duration data, I don't know that we can make that mandatory, but I think certainly awareness of antibiotic resistance and stewardship is an important part of, veterinary medical education. So that's where we've been focusing some of our efforts. That's a really good point and not one that I'd ever considered before.
And I'm not sure if you saw the last question, you kind of alluded to it a little bit regarding the pharmacy companies giving free things, fishing trips, etc., to bovine practitioners. Do not believe that this impacts their prescribing habits. How can we convince DVMs it's really a conflict of interest? And I know that we do have some large animal folks on the committee, so you could probably speak to their involvement and their dedication to stewardship.
Yeah, so being that the most I usually get is a pen, I wasn't aware that the large animal folks got those perks. But that's something that we can put on our agenda and sort of discuss for our next working group meeting. I do think that whether it's probably conscious or subconscious, there is some loyalty. If anyone is involved with any of the veterinary feeding programs through any of the big pet food manufacturers, does that influence us? Well, I don't know that was really fair for us to say that it doesn't. So I'm sure that there is an impact there. I guess the other thing is that we have to be cognizant of where we're getting our CE from, because ultimately, manufacturers of vaccines and drugs and food are for-profit organizations, and so we need to just make sure that we use a critical eye, and that's something that we try to teach our veterinary students as well.
Another question that came in to me is, in discussion with colleagues, what is missing is more guidance, written guidance for prescribing across species. Do you feel that that's accurate?
Yes, I feel that is 100% accurate. So the ISAC guidelines are a great place to start. They are guidelines, and right now that's just a small subset of the things that we prescribe antibiotics for. Also, guidelines are tricky because they appear to be black and white, but when you have a patient with comorbidities or other challenges that we have, whether they're diagnostic challenges or owner challenges, it makes it really hard to always follow those guidelines. I do think that more guidelines are needed. I know ISAC and other groups are working on that. And one of the things that we're trying to do through the One Health Collaborative is to take those guidelines as well as evidence-based information, if guidelines don't exist, to try to provide our own. And so we'll be trying to distill all of that information and put it into these fact sheets. We're trying to think of other ways that we can help. And so if anyone has ideas of what specifically you think could help you in a practice, let me know. The British Small Animal Veterinary Association provides for their practitioners these big posters, and it's basically a way for practices to make a plan. So for each, say, organ system or disease process that are typically encountered, the practice can take into consideration maybe what their regional antibiogram tells them, and then they can make decisions about what they think are good empiric choices, and in what situations do they really feel like they want to advocate for cultures before they prescribe, and so on. And so we're thinking about those types of things. One of the things we're working on right now is a non-antibiotic prescription pad so that you can communicate supportive care, things to look out for, when to follow up for owners when you don't think an antibiotic is necessary for a particular patient. This way, the owner knows that you are, not ignoring their concerns. You are providing them with specific instructions if they just don't at this time happen to include an antibiotic. So we're hoping those types of things will be helpful too. But I do think that we need more guidelines. And unfortunately, guidelines right now are largely where we don't have evidence. They're largely expert opinion. And I think that there's a lot of low-hanging fruit that we can go after as far as research studies. And so Amanda and I have, in the last probably 6 months, been involved with lots of conversations with different folks at universities and health departments across the country. So there's a lot of momentum here. So I do think that those things will be coming.
Great, thank you for that. I am not currently seeing any more questions that came in to me directly or that you haven't already answered in the Q&A box.
Great. Well, I appreciate everyone spending their lunch hour with me. Oh, Amanda, there's a message I'm just going to read you from Amanda real quick. We wanted to thank you all for your attention today and to let you know that this webinar today as well as the rest in the series will be archived online, and we'll provide attendees with a website link. And we'll promote the use of webinars widely for use in staff training and education. So if you think anything that you heard today is worthwhile to share with others in your practice, please feel free to share the webinar. Our next webinar will be on May 7th, also at the noon hour, and this will be given by Dr. Scott Weiss from Ontario Veterinary College, and he is one of the group with ISAC that developed the current guidelines, and so he's going to talk about the use of peer-reviewed guidelines, treatment guidelines to improve prescribing in small animal medicine. He's a really engaging speaker, so if you're able to attend, I think you'll really enjoy that hour. So thanks again, everybody.
Yes, thank you, and have a great week.
You too.